So I'm really excited. I've seen Dr. Bespalova present before. She has an incredible career here at the University of Washington, so I'm excited for our talk today. It's titled Substance Use and Mental Health in the Perinatal Period, Challenges, Opportunities, and Treatment Approaches. Dr. Bespalova is a physician and perinatal education psychiatrist at the University of Washington. She completed medical school at the Baylor College of Medicine, general psychiatry residency at NYU School of Medicine, and then addiction psychiatry fellowship at the University of Washington. She splits her clinical time between the maternal infant care clinic and outpatient psychiatry clinic at the University of Washington and at the Madison Clinic at Harborview Medical Center. Her scholarly interests include substance use disorder in the perinatal period and medical education. So I'm really excited to welcome Dr. Bespalova, and I will be turning the screen over to her.
All right. Hi, everybody. Excited to be here and give this talk. Let me share my screen. Okay. Okay, and everybody hopefully is seeing the correct screen and not the presenter view. Okay, great.
Yes, we're good. Thank you.
All right, I get it wrong every time when I have two screens. So yes, happy to be here and to be giving this talk. I will apologize in advance. I was just telling Monica and Maureen that I am getting over a cough that my children have gifted me with, so you may hear me coughing intermittently. I will do my best and apologize in advance. So just like Monica said, I am a perinatal and addiction psychiatrist here at the University of Washington. So this is a topic I'm really passionate about, and I'm really excited to talk to you all about it. I hope that this can be like as interactive as we can make a Zoom lecture with like 200 to 300 people in it. So please feel free to ask questions as we go along, put them in the chat, or if you want to unmute yourself and ask. We'll have time at the end as well. So just whatever you feel like makes the most sense for you. Okay. Okay. So I don't really have any disclosures except that I do work for the Perinatal Psychiatry Consultation Line, which is a provider consultation line that is operational weekdays 9 to 5. Call us if you have questions about anything that a perinatal psychiatrist can help with. You will be connected with a social worker and a care navigator, and then usually we can get you connected directly with a perinatal psychiatrist that can help you think through cases, answer questions. Okay, so some learning objectives I have for today. I hope to describe to you all, give you a sense of the epidemiology of substance use in the perinatal period and what patterns of use look like. Talk about the role of stigma and discrimination in substance use policies and treatment for people in the perinatal period. I hope you can walk away knowing a little bit about how to screen for substance use in pregnancy in the perinatal period in a systematic way. We'll talk, of course, about risks associated with kind of the most commonly used classes of substances. So that will be opioids, alcohol, cannabis, stimulants, and tobacco or nicotine. In pregnancy, we'll talk a little bit about lactation and chest feeding as well. And then we'll talk about some treatment options and considerations for substance use disorders in pregnancy. I will be talking some about medications, especially when there is an evidence-based role for medications, and then some non-pharmacologic treatments as well. Okay, so we'll start a little bit with a little bit of an overview of like, what does substance use in pregnancy look like? How common is it? How much of an issue is it? Well, it's a difficult topic to study because, as many of you may imagine, this is not something people are necessarily volunteering to disclose. We do have some data from this 2012 survey conducted by the Department of Health and Human Services of pregnant people in the US. It was an anonymous survey where about 16% of people said that they smoked cigarettes, about 9% said they consumed some alcohol, and 6% used illicit substances. So because this was a national survey, illicit substances for this survey would include cannabis. We know that rates of opioid use and opioid use disorder in pregnancy are increasing because there is a national epidemic of opioid use disorder. We know that the most common substance used by pregnant people is cannabis, but this is followed closely by cocaine and methamphetamines. And as a lot of you might be aware, especially here on the West Coast, but really throughout the country, there is a rise in methamphetamine use and methamphetamine use disorder. And then, of course, use of more than one substance is common, right? So especially for folks that are using substances, not just recreationally and occasionally, but more in kind of a heavy, routine, problematic way, a lot of times they're using more than one substance. What are some risk factors for substance use in pregnancy? I think a lot of these are quite intuitive. So unplanned pregnancy, being younger, so being less than 25 years of age, living in a household at or below poverty level, comorbid psychiatric disorder. So you will see this kind of as a theme throughout this presentation. I think, excuse me, a lot of times what I see in my work is that kind of the substance use disorder world and the addiction world is really like quite separate from the mental health space, when really I think of them as kind of parts of the same issue. A lot of people that have mental health conditions also use substances or meet criteria for substance use disorder, and then vice versa is also true. Trauma history is a huge risk factor, and then family history of substance use disorders. I would say this is, not necessarily that something came out of this particular paper, but in my experience, partner use is also a big risk factor. Okay, so let's take a few minutes to talk about stigma. I think you really can't talk about this topic without talking about how stigmatized it is. And so that's why it's so hard for people, for our patients, for our clients to talk about it. Kind of like starting with a zoomed out perspective, there's tons of social stigma toward people who use substances. This is often compounded in pregnancy and parenting. So as you can see this Time magazine cover, the goddess myth, right? So a lot of times in society, right, there's this view of mothers as, being perfect, giving up everything, sacrificing everything for their children. And if you're not doing that, then you're not a good mother, so to speak. I think to some extent this can be extended to parenting in general, but I do think it disproportionately affects mothers and those who identify as mothers. And so really like the idea of using substances for a lot of people that does not go along with this idea of being the perfect mother. A lot of like, how could you be doing this to your baby? How could you possibly be taking care of children or a child if you're using substances? And then, of course, kind of thinking about intersectionality and where the identity of being pregnant or being a parent intersects with other identities, thinking about how we view substance use among like white folks differently than we do in people of color. Okay, so then how about in healthcare, right? So zooming in a little bit on like, what do people experience when they go and they seek care? And that could be substance use disorder care, mental health care, prenatal care, anytime they interact with the medical system. So we know from studies, and I think this is a surprise to nobody, that healthcare professionals have a negative attitude toward people who use substances. There is a tendency to over-attribute medical problems to substance use. In this study that was done, it was found that healthcare providers were less involved and more task-oriented with people who use substances. So very much like what needs to happen, what do you need to do? And then there was less personal engagement and diminished empathy in healthcare encounters. So this is just kind of generally speaking, people who use substances, not specific necessarily to people in the perinatal period. We also know that there's a huge amount of racism in medicine, right? And how that impacts kind of how substance use is viewed, discovered, and acted upon and treated. So there was a study back in 1990 in Florida where they saw that doctors were 10 times more likely to report Black women than white women to government authorities for substance use, despite similar rates of substance use. And you may say, oh, well, hope that was back in 1990. Maybe we've come a long way since then. Well, I wish I could say that were true. But there was actually a study of electronic medical records from 2018 to 2021 in a large hospital system in Pennsylvania. And what they saw is Black patients, regardless of history of substance use, had a greater probability of receiving a urine tox screen at delivery compared with white patients and other racial groups. Black patients did not have a higher probability of a positive test result than other racial groups. As you can see, this is a map, and the states in red are the states where substance use is during pregnancy is considered child abuse and can be reported and treated as such. As you can see, Washington is not in red, so is not one of those states. But I always remind people that, of course, we work with people that are from like all over the country, and people don't necessarily know this. And a lot of times, people are scared to disclose substance use when they're pregnant to anybody that's they view as someone who's going to report them. Their parental rights are going to be terminated. CPS is going to be involved. And so even though substance use in pregnancy is not reportable to CPS in Washington, people don't necessarily know that. And it may be different kind of where they come from and experiences they've had in the past. What are the impacts of local policies on treatment and outcomes of substance use disorders in pregnancy? Well, we know that states with laws that permit child abuse charges for illicit substance use in pregnancy actually have less utilization of medication-assisted therapy for opioid use disorder in pregnant individuals, which is, of course, the standard of care for opioid use disorder in pregnancy. So what we're seeing is actually states that have these policies have people be less likely to receive appropriate care. We also know that states with punitive policies related to substance use in pregnancy had significantly greater odds of neonatal abstinence syndrome during the first full calendar year after such a policy was enacted. So, we may ask ourselves, like, who are these policies for? Who are they benefiting? They're certainly not benefiting the pregnant individuals and their children. Okay, so taking a few minutes to talk about the relationship between trauma and substance use. I think that this is hopefully not new information and kind of intuitive to a lot of you, but I just kind of like to put it in a visual. So we know from the ACEs studies that adverse childhood experiences have a dose-dependent impact on early initiation of substance use, problems with substance use, and going on to develop a substance use disorder, and then IV substance use or injection substance use. So the more adverse childhood experiences you have, the more likely you are then to go on and start using early, and then also have it not just be kind of like a recreational occasional thing, but actually for it to become an issue. And so what does this look like? Again, this is just kind of a crude image. This is not necessarily how it looks for every individual in every situation, but you can think about, somebody having a traumatic experience or many traumatic experiences. They may develop PTSD, anxiety, depression, kind of general distress related to their trauma. They're seeking escape and relief. They use substances. And then as this continues, they may engage in behaviors or be in an environment that is associated with substance use that then predisposes them to like future traumatic experiences, right? So you might think about, somebody who is buying illicit substances is certainly going to expose themselves to dangerous situations that might, involve things like, sex work or, kind of being involved in situations where you are likely to experience further trauma. And if you think about like kind of adding a child to this loop, right? So then let's say this person who's kind of moving through the cycle then has a child, and then the child is kind of in this environment of potentially kind of, things that go along with substance use, maybe unsafe behaviors and unsafe environment, then they have traumatic experiences, and then now they've entered the cycle as well, right? So you can see how this kind of goes generation to generation. When we talk about there being like a genetic component to substance use disorders, I think genetics play a role, but I think that this kind of loop is a big part of it as well. Okay, so trauma-informed care, just kind of a brief kind of mention of it. There are tons of great presentations on this out there, but just kind of reminding everybody that, like, what does trauma-informed care really mean? Well, we're hoping to shift the paradigm from what's wrong with you, why are you doing this, to like what happened to you and how is it impacting you now? Just the 4 R's of trauma-informed care: realizing, recognizing, responding, and resisting re-traumatization. And then there's kind of this image about like what are the components of trauma-informed care. Okay, so when working with people who use substances or have substance use disorders, I always remind people that language really matters. So I have a list here of terms I prefer to avoid, and those include terms like alcoholic or addict, drug abuser, addicted baby or baby born addicted. That is one in particular that I have a soapbox about. I still see this term all the time in the media and people mention it. I remind people that addiction is a really complex psychosocial phenomenon that a newborn infant is not capable of. They are not addicted. They are maybe impacted by perinatal substance use or exposed to substances perinatally. That's different than being addicted. Drug problem, drug of choice, referring to urine screens as being clean or dirty, or referring to medications as substitution or replacement therapy. And instead using terms like more neutral, kind of taking a more neutral stance of saying person who uses substances, substance use disorder, infant with perinatal substance exposure, or opioid exposure. You can say risky use or non-medical use. You can simply refer to substances somebody uses. You can say a drug screen is positive, negative, or aberrant or unexpected. And then you just call it medication for opioid use disorder or medication for X condition. That's often abbreviated as MOUD. And you'll see that term later on in this presentation. Sometimes I get the question from people about like, well, what about the patients themselves use this language, right? So especially people that are kind of in certain recovery communities, for example, like AA or NA, right? They may say self-identify as an addict. They might say like, well, I'm an addict or I'm an alcoholic. I always say like, that's fine. Patients can use whatever language they like to use and whatever works for them. But for us as providers, I think it's important that we use this terminology. And you can always also have a conversation with the patient about what terms they prefer. Okay, so talking a little bit about outcomes for substance use. And when I give this presentation, I often say that if there's one slide from this presentation that I hope you remember and take away from this, I hope it's this slide. And this is a study that tracked people that used substances in early pregnancy and looked at what happens to them. And here's what they found. A lot of people were able to stop using substances in pregnancy. So they saw that a very high percentage stopped using alcohol, fairly high for stopping cannabis use and cocaine use, not as great for cigarette use, right? We know that tobacco nicotine is very, very hard to quit. But then when they tracked people postpartum, they saw that a good number of them had relapsed by 3 months postpartum. So, about half for nicotine and alcohol, a little less than half for cannabis. And then it did pretty well for cocaine. I guess a lot of people were able to go on avoiding cocaine use. When they then came back and checked in with those people at 2 years postpartum, 80% overall had relapsed to prior patterns of substance use. That's important, right? Because what you're going to see in this presentation is a lot of times the adverse impacts of substance use are less related to prenatal exposure itself and more related to kind of the adverse social environment associated with substance use in the family. So that makes the slide extremely important because a lot of times the focus is on getting people to stop using substances in pregnancy. You're hurting your baby, You're not being a good mom if you identify as a mom. This is what you need to do. And then after you have the baby, all of the attention shifts to baby. People sometimes lose their medical coverage. They're certainly not as closely followed by the medical system. They might lose a lot of supports they had in pregnancy. And also kind of everybody stops paying attention, right? And in addition to kind of all the stress of new parenthood, it's an extremely high risk time for relapse. And I don't think we pay enough attention to that and disproportionately focus on pregnancy itself. Okay, so screening for substance use. So the American College of Obstetrics and Gynecology recommends using what's called the SBIRT model. SBIRT stands for screening, brief intervention, and referral to treatment. So that's what they recommend, a prenatal provider does. They recommend everybody screened at first prenatal and preconception counseling visit. A lot of times the way I see it happen in practice is that there's kind of like a very brief question about it. Like, do you have any substance use issues? Are you using any substances? And then the conversation moves on. I think it's important to ask about use currently and pre-pregnancy to really understand somebody's risks. A lot of people might have quite risky substance use or substance use disorders, and then they're going to stop using when they find out about pregnancy. But that still means that overall, their risk for relapse in pregnancy and postpartum is higher than somebody who's never had an issue with substances. You want to be specific. You want to clarify amounts and modes of use, because a lot of times that's going to change kind of your risk stratification, might change some, additional workup you want to do and things like that. There are some standardized screening tools that are specifically validated in the pregnant population. So that's like the 5 Ps that asks about parents' use, peer use, partner use, past use, and present use. And then the NIDA quick screen, which I have here. The image for some reason always shows up a little blurry. But as you can see, it's kind of very short. And it's a tool that can be used for anybody. And this is kind of the initial screener, where it asks you in the past year how often you use all of these substances. And then on the NIDA website, if this screener is positive, then there's kind of a longer interview you can conduct. A couple things to mention. Obviously, somebody who is pregnant, the kind of bar for more risky alcohol use is going to be a lot lower than for somebody who's not pregnant. And then I think given that where we live in practice, cannabis is legal, there's kind of no obvious place cannabis would fall here. So sometimes, I ask people to like include that with tobacco or something like that. Okay. So now we're going to shift a little bit and we're going to talk about some specific substances, like I said before, and talk about what use looks like and what treatment looks like. So starting with opioid use and opioid use disorder, we know that prevalence of opioid use disorder in pregnancy is increasing. So diagnosis, at delivery, hospitalization increased from 1.5 per 1,000 births in 1999 to 6.5 in 2014. And unfortunately, this number, it kind of goes up and down year to year, but the trend is still, unfortunately, overall in the up direction. What are some risks of opioid use in pregnancy? Well, separating it out to risks to the birthing parent and then risks to the baby. So for the birthing parent, of course, there's risk of overdose. People who have opioid use disorder are less likely to receive appropriate prenatal care. They're more likely to have infections. They're more likely to have mood and psychotic symptoms, both induced by the substance itself and then maybe worsening of underlying conditions. They're at higher risk for unintended pregnancies, abuse and other trauma, and then legal consequences, including loss of parental rights. And then risks to baby. So there's a higher risk of intrauterine fetal demise and stillbirth, preterm labor, low birth weight, neonatal opioid withdrawal. So you'll see these terms largely used interchangeably: NAS, which stands for neonatal abstinence syndrome, and NOWS, which is neonatal opioid withdrawal syndrome. So it's just a more specific term. NAS can be used for kind of a variety of substances and sometimes is even used to describe the impact of certain medications in the postpartum period, whereas NOWS is specific to opioids. Infants tend to have longer hospitalizations after birth and a higher chance of rehospitalization within 30 days of birth. So the standard recommendation is to use medications for opioid use disorder in pregnancy. And so medications for opioid use disorder, abbreviated as MOUD. What are the benefits of medications in opioid use disorder? Well, it increases engagement in prenatal care, decreases rates of HIV and other bloodborne pathogens, provides a more stable social environment, decreases overdose risk, and decreases the risk of the baby having NOWS, and if they do develop it, the severity of it. What are some options for medications for OUD in pregnancy? Well, there are kind of three medications we think about for opioid use disorder, and they're methadone, buprenorphine, and naltrexone. So in studies specifically done with pregnant individuals, there was a big randomized control trial called the Mother trial that looked at this. They saw that methadone was associated with improved treatment retention. Buprenorphine was associated with decreased NOWS severity. So there's kind of pros and cons to each medication. And then naltrexone is a medication that up until recently hasn't been studied much in pregnancy, but there is more and more data coming out about it. However, in order for somebody to start this medication, they have to fully be detoxed from opioids, which has incredibly high failure rates. And for that reason, it's not recommended to start it in pregnancy. That being said, if somebody is already on this medication and doing well, and then they become pregnant, it's certainly worth it to have a conversation to continue this medication. And what I always remind trainees I work with, medical students, residents, is the most effective medication is the one that the patient is going to take. So this is kind of, because methadone and buprenorphine are the ones that we most commonly use, I would say by far, we use more buprenorphine just because of ease of access to it and because it can be prescribed in an office setting. Whereas, of course, methadone for opioid use disorder can only be prescribed in a specific clinic, a methadone program, so to speak. But I do think it's an option that we should remember. So these are just kind of some pros and cons I talk through with my patients if we're thinking through what might be a better fit for somebody. So for methadone, there are kind of more barriers to getting it, but that also means that there's kind of more case management and support that might be available through the methadone program. If you are on methadone, then switching to buprenorphine is more difficult. It also has a pretty slow stabilization and titration schedule, has more drug interactions and a higher overdose risk. That being said, it can be a little bit easier to start methadone than buprenorphine because with buprenorphine, of course, you have to wait until you're in some amount of withdrawal. There's some newer kind of fancy ways of starting buprenorphine, maybe not that new at this point, like microinduction protocols. I won't go into details about that. There's can point people to resources if that's something of interest to you. But in general, buprenorphine, right? You can get it in an office. The requirements for like a specific waiver to prescribe buprenorphine have been stopped. And so now any person who can prescribe medications and has a DEA license can prescribe buprenorphine. It is pretty easy to switch to methadone if you need to. You can stabilize pretty rapidly on this medication. It doesn't have a lot of drug interactions, has a very low overdose risk. There is a risk of precipitated withdrawal if you started too early. And it does have a lower NOWS severity in studies, buprenorphine compared to methadone. Okay, so shifting gears to alcohol. Alcohol in pregnancy, again, difficult to measure and underreported. About 10 to 15% of women say they use some alcohol during pregnancy, and then 3% report binge drinking at some point during pregnancy. There was a study that looked at what happens to people who use alcohol in pregnancy, and they saw that 87% quit completely, about 6% reduced their use, and then about 6% didn't change their use. Um, Alcohol, of all the substances we're going to talk about, has the most well-established adverse fetal health effects. And so they're both risks to the pregnancy, like miscarriage, stillbirth, and infant mortality, congenital anomalies and abnormal facial features, low birth weight, and reduced gestational age. And then there's, of course, fetal alcohol spectrum disorders. This is what we used to call fetal alcohol syndrome. But it's really quite a range of presentations that varies quite a bit in severity. And so a lot of us kind of from like training or textbooks remember these like pictures of children that were like the classic fetal alcohol syndrome facial features. But, you know, really it can look a lot of different ways. It can be quite mild or quite severe, but it basically consists of adverse neurodevelopmental outcomes, including cognitive and behavioral challenges, adverse speech and language outcomes, executive functioning deficits, and psychosocial consequences in adulthood. This question comes up all the time. Is a mild to moderate alcohol use okay? Right? So a lot of times people want to know, well, it's, you know, my anniversary, it's a really special occasion. Can I have a glass of wine? Can I have half a glass of wine? This is a difficult question to answer, I think. What we do know for sure is that there is a dose response relationship, right? So the more you drink, the worse it is. We also know that there's a great variability in maternal alcohol clearance rates. And there's a lot of kind of genetic factors that change how somebody metabolizes alcohol, how long it takes. This is also impacted by the timing and duration of consumption. We know that fetal blood alcohol concentrations do reach levels that are nearly equivalent to the pregnant person's, and elimination is quite slow and variable. There are some studies that do show little difference between children of mothers who consumed low amounts of alcohol and those who abstained completely. However, rates of miscarriage were still higher in the mild to moderate consumption groups. And usually what you'll hear people say is that we just don't know if they're like, there's no safe threshold, right? Like you can never tell somebody, oh, up until this amount is okay, because we just don't know. It depends on where you are in the pregnancy. It depends on your individual genetics. It just depends on a lot of different factors. And then, of course, I have the Expecting Better book by Emily Oster, quite a famous book here, because one of the things that she talks about is kind of based on her analysis of the data. She is a statistician, I believe. She seems to be of the opinion that low-level alcohol use is okay. So a lot of people read this book, cite this book. Okay, so if we're talking about alcohol use disorder in pregnancy and how we manage that, well, we have some medications for alcohol use disorder. They don't work tremendously well, although some of them do work. Non-medication treatment is key here. And so that can consist of motivational interviewing, excuse me, or motivational enhancement therapy, cognitive behavioral therapy, or self-help groups, or mutual help groups such as AA. There's no data that suggests one mode of treatment is more effective than another, specifically for alcohol use disorder. There's been some pretty cool, like large studies looking into this. And the best treatment is the one that the patient is willing to engage in and that kind of works with their formulation of their problem. I like to remind people that pregnant people in particular may have more difficulty engaging in an alcohol use disorder treatment. So if you think of somebody who is like visibly pregnant showing up to an AA meeting, people might make comments, people often feel quite uncomfortable. When it comes to medications, there are 3 medications with FDA approval for alcohol use disorder. Those are naltrexone, acamprosate, and disulfiram. Of those, naltrexone has the most reassuring data in pregnancy. Acamprosate and disulfiram have very, very little. And so in general, we don't recommend the use of those medications, especially disulfiram, because in some small studies, it was suggested that it has a risk of fetal malformations. And then gabapentin is a medication that's, has like off-label use for alcohol use disorder. That medication is generally considered compatible with pregnancy. And what I tell people when it comes to these medications is really it just comes down to like a very careful risk discussion. So you want, if you're talking about this with somebody, you want to talk through the risks of the medication and the risks of being off the medication. Just because the risks associated with alcohol use are so high, it's worth it to have this conversation. Okay, moving on to cannabis. This is a topic that's kind of a hot topic right now, with increasing rates of cannabis use and kind of increased public perception that it's safe and that it kind of works for a lot of different things. Of course, a lot of people use it in pregnancy for nausea and vomiting. In addition to, people use it for like anxiety or sleep or recreational reasons. I actually just gave a talk yesterday that was an entire talk on just cannabis use in the perinatal period. So this is just kind of some snippets. It's important to know that in general, it's perceived as being safe by the public, including during pregnancy. Cannabis does cross the placenta and is also found in breast milk. Prevalence of use in pregnancy varies in studies, but is quite high. And in general, people who use cannabis on kind of a routine basis do continue using during pregnancy. And it's certainly rising over time. I think that this is a really interesting graph. This looked at the probability of people responding that using cannabis once or twice a week has no risk in pregnancy. And as you can see, so the kind of data separates out a little bit. So on top, the yellow and gray lines are people who use cannabis. So it makes sense, right, that they would be more likely to think that there is no risk with using cannabis once or a couple times a week. And as you can see over time, kind of they're going in the, trending together in the upwards direction. So more and more people are saying, yeah, there's no risk associated with cannabis use in pregnancy. I think what's interesting is at the bottom, like orangish, kind of burnt orange and blue lines are people who don't use cannabis. And even those people seem to kind of increasingly think that there's no risks associated with cannabis use occasionally. So what are the risks of cannabis use in pregnancy then, right? So I think this is kind of not very satisfying because the data is quite mixed and inconclusive. There are some earlier studies that maybe showed that there's like not a lot of risks associated with cannabis use in pregnancy as far as like perinatal morbidity and mortality. Then there was a later study that did show that cannabis use in pregnancy was associated with low birth weight, preterm labor, infants being small for gestational age, and likelihood of being admitted to the NICU. It did appear dose dependent. And one of the theories as to why this may be happening is just because the potency of cannabis is increasing over time, as far as like the percentage of THC in the cannabis products is becoming higher and higher. I think, some of this data with like the perinatal outcomes, it's kind of hard to interpret. It's largely confounded, right? So a lot of times people that are using cannabis are also using nicotine. Sometimes, they're more likely to have pregnancies that the pregnancy was unplanned. And so maybe they weren't taking like prenatal vitamins and all kinds of factors that might be contributing. There is kind of more and more data, and a lot of, this is from some large studies that have followed kids that were prenatally exposed to cannabis long term, that I think is concerning. I think it's a little bit early to say kind of what to make of it exactly, and how much it's, again, like a result of other factors in the social environment. But these studies are showing overall reduced attention and executive functioning skills, poor academic achievement, higher likelihood of behavioral problems, sleep issues, psychotic symptoms in children exposed to cannabis prenatally. I think it's reassuring to know that exposure only prior to knowledge of pregnancy was not associated with these outcomes. So sometimes, I have patients that will get very nervous and ask me like, I didn't know this is unplanned pregnancy and I was using cannabis quite heavily. And, I stopped, or I'm like working on stopping, but I'm really worried. I saw some of this on the internet. And I think it's, something reassuring you can discuss with folks. This is also comes up often. Cannabis with lactation, breast or chest feeding, and how to think about that. Unfortunately, data in this area is extremely limited. We do know that THC passes into breast milk. THC loves to hang out in fatty substances. It's very lipophilic. And so in one study, THC was present in breast milk in measurable amounts up to 6 days after use. And there's one study that showed that exposure to THC through breast milk in the first month of life could result in decreased motor development at age 1. This study did not follow children after that, so we don't know how significant this was. Did these kids catch up? We don't know. There's another study from even earlier that didn't show any differences. So there's really 2 studies. If you look at the literature on this, there's a lot of speculation, a lot of people talking about well, it passes into breast milk and this could be true and this could be true. And these are animal studies, but there's actually very few studies looking at the real world effects of this, which makes it kind of a difficult topic to talk about because the answer is we just don't know. And the 2 studies that do exist are from 85 and 90. So I don't know why nobody is doing this research, but we're not. So, talking a little bit about problematic cannabis use or meeting criteria for cannabis use disorder, which of course does happen. I think a lot of people view cannabis as so safe and unproblematic that kind of any amount of use is okay. But of course, we do know that people can develop a dependency and issues with cannabis use. There's no approved medications for cannabis use disorder. We recommend treating comorbid conditions. So, often people don't know that there's medications that they can take in pregnancy for things like anxiety, mood disorders, insomnia, and nausea. And then also I like to discuss this carefully with people. So a lot of times people will say that cannabis is helping their anxiety, and that could be true, but it's also important to distinguish that from people are experiencing withdrawal from cannabis, which consists of anxiety, low appetite, insomnia, and irritability, and then treating that withdrawal with cannabis. Okay, shifting gears to stimulants. So overall, the rates of cocaine use are going down, but rates of meth use are going up. Methamphetamines are, of course, often used with opioids intentionally and unintentionally. So we know more and more methamphetamines and even other substances that are kind of sold on the streets are contaminated with fentanyl and fentanyl analogs. I often have this conversation with people that, they're like, oh no, I don't use opioids or heroin, I only use meth. And they don't realize that there may be fentanyl in the meth that they're using. And because they don't have any tolerance to opioids, they're also then more likely to die of an overdose if they are exposed. It doesn't take very much fentanyl to kill someone who doesn't have any tolerance to opioids. And then there's things like carfentanil, where a very, very tiny amount can kill someone. What are the risks? Well, breaking it down, so with cocaine, a lot of risks with stimulants have to do with the elevated blood pressure that's associated with stimulant use. So for cocaine, that can include things like premature rupture of membranes, placental abruption, preterm delivery, low birth weight, and babies being smaller than expected. Longer term data is kind of mixed. Some studies suggest negative impacts on development, and then there was actually a review of 36 studies that show no compelling evidence that prenatal cocaine exposure is associated with adverse outcomes that cannot be attributed to gestational age of delivery, caregiver psychiatric comorbidities, and other prenatal exposures or quality of postnatal environment. So again, I think that this makes me think of that slide I showed you in the beginning, where that postpartum relapse risk becomes very important. Because if the risks to baby of cocaine use have more to do with kind of use in the family, so to speak, then that's something we should be paying attention to. With methamphetamines, kind of similar risks, low birth weight, preeclampsia, gestational hypertension, intrauterine fetal demise, kind of mixed data on congenital anomalies. There might be a higher risk for cleft palates. Newborns can develop kind of like a syndrome of jitteriness, drowsiness, and respiratory distress after delivery, and they do have a higher rate of NICU admission. This is an image from a paper that kind of just walks you through kind of how some of these risks manifest and where they come from. So there's kind of the like hypertension and decreased uterine blood flow and like kind of how that leads to growth restriction. And then there's like the effects of environment, of, inhaling meth, and all of those kinds of things. And so when it comes to longer term outcomes, there's a nice study that was done in the US and New Zealand that looked at 412 maternal child pairs, compared methamphetamine exposed and unexposed children. They did try to control for use of alcohol, tobacco, cannabis, and for maternal depression. At age 3, they saw, again, going back to this pattern, that neurobehavioral outcomes were associated with adverse social environments and not prenatal methamphetamine exposure. That being said, heavy exposure, so more than 3 days a week, was associated with higher rates of anxiety, depression, and attention problems. So treatments, I think this is like a really hot topic. We're all hoping for a treatment for methamphetamine use disorder. For everyone, not just for pregnant individuals. But unfortunately, everything that's been studied and a lot of medications have been looked into for this, it just doesn't seem to work. There's some studies supporting use of mirtazapine, bupropion, and bupropion with naltrexone. Evidence is like, I think sometimes for people that aren't pregnant or lactating, it's kind of can be a little bit like, well, why not? Let's just try it, right? It's not going to be worse than meth. I think for pregnant people, certainly if somebody's saying, oh, I used to be on this medication and it really helped me avoid meth, I think that's worth it to have a conversation about it. We do recommend treating withdrawal and comorbid conditions. I often remind people that you shouldn't forget about ADHD. Right. So we know that people with untreated ADHD are very likely to self-medicate with stimulants, and will often say that, the first time they used cocaine or meth, they suddenly felt like their mind was clear and they could actually like focus and do what they needed to do. And I think it's important we pay attention to that and look at what might be going on there. And the best evidence for methamphetamine use continues to be for behavioral treatments such as contingency management. Contingency management is offering rewards for either like negative urine drug screens or coming in for appointments, or like kind of rewarding recovery behavior. And because the rewards cost money, few places offer it, unfortunately. But it has the best evidence. And wrapping up with tobacco and nicotine. Use is actually declining over time. I mean, we do know that people are kind of smoking less, although there's kind of more vaping recently, right? And there's like some lack of clarity about that, and also kind of just depends on what it is that you're vaping. Risks of nicotine exposure. There are some risks, including ectopic pregnancy, low birth weight, preterm birth, kind of similar risks that are emerging between these substances. Importantly, there is a higher risk of respiratory and ear infection and sudden infant death syndrome when there is smoking in the household. There's possibly an increased risk of ADHD in children and a higher risk of going on to develop an addiction to nicotine. Treatment. So, there are some medications that we use as far as psychosocial treatment. In one study, counseling throughout pregnancy was associated with a 44% increased likelihood of abstinence from tobacco in late pregnancy. So that's pretty cool. In that same study, they found that brief counseling, so when somebody talked to the patient once for less than 5 minutes and basically said, don't do that, smoking is bad, was not effective. So if you are going to be talking about it, you want to be returning to the subject and checking in with people about it. Nicotine replacement therapy, so those like your gum and your patches and your lozenges, is an option. It actually, when they look at use of NRT, they don't show any negative or positive effect on birth outcomes. But it does seem to help with smoking cessation. And ACOG just kind of says that if you are going to use NRT, it should be undertaken with clinical supervision and after consideration of the risks of continued smoking. Varenicline is Chantix, right? So that's also something we use sometimes. There's little data for it in pregnancy, and then bupropion is sometimes used. Again, little data specifically for smoking cessation in the pregnant population. This is a table that I like. So of course, this references like the various studies, but I think it's a nice summary because it's for every like commonly used substance, it breaks down different potential adverse outcomes. And then the check mark just represents that there are studies that show an association of that substance with that particular outcome. It does not mean that like, the research is final and clear. It just means that there's some evidence out there suggesting an association. And it can be like a nice, I think, reference for if you just kind of, people are asking and you don't remember, and you can look at this. Okay.